Thank you. Our last presentation will be by Saumil Desai. Dr. Saumil Desai is a student neonatologist consultant at PCH and with NETS, and he wants to share with us experience of transported outboard infants less than 32 weeks, especially with intracranial bleeding perspective. Thank you, Saumil.
Thanks, Matt, for that kind introduction. I'm representing a team, as you can see here, from NETS WA, also King Edwards, and also the Kids Research Institute in Australia. Just would like to start off by saying that there is nothing to say in terms of funding. And to put some facts in place, Western Australia has the world's largest global retrieval area, spanning 2.6 million square kilometers. We cater to 34,000 births every year. 3% of this do require retrievals to come to the sole units here in Perth Children's Hospital and King Edwards, and they amount to 1,200 per year, out of which 150 or roughly 10% are born less than 32 weeks. So they are outborn preterm infants outside King Edwards, and longest trip can take around 2,200 kilometers, and they can almost take up to a day for us to get these babies back to Perth. The rural and remote retrievals constitute roughly 1/4 to 1/3, somewhere between around 30% of the total retrievals. Aboriginal infants constitute 5% of total retrievals and 12% of the total rural retrievals. Over the period of last two, as you can see here, that the number of outborn preterm infants were somewhere around 5 to 6% in the year 2005, and they've grown up to now 11 to 12% in the recent data. So we are seeing increasingly more number of outborn preterm infants who are born outside King Edwards and who are being retrieved back to King Eddies by NETS WA. This is another piece of recent work from our team, and it clearly shows that those particular infants who are born 32 weeks and below and outside King Edwards would have higher odds of death and higher rates of intracranial hemorrhage. Odds were 2 to 2.5 times higher as compared to those who were born inside King Eddies. So for our research, what we did was to assess a lot of these factors which would probably be associated with intracranial bleeding in outborn preterm infants. And we looked at maternal factors, rhesus factors, infant factors, and also the transport factors that could be potentially associated with intracranial bleeding in outborn preterm infants in Western Australia. This was a retrospective cohort study spanning 11 years. We excluded those infants who were transferred after the day 1 of life, those who had major anomalies, or in whom we couldn't do a head scan on day 1 of life. Analysis was done by the tests, as we have mentioned here, chi-square test and Mann-Whitney test. Importantly, we also did the log analysis to try and adjust for those factors which could not be modified and looked at those additional factors. So total of 10,400 transfers happened in that particular period that we looked at all these outborn infants. 32 weeks and below, we had 297 infants who were transferred, out of which we had to exclude 11 because 11 died before any scan could be done. 7 died before any scans were done. 4 were with major anomalies. So we had a total of 286 infants who were available for analysis, out of which 57 infants had intracranial bleeding that was detected on day 1, which amounts to 19.9%. And after day 1 of life, 11 infants died in King Edwards. So we had a total of 275 infants who were analyzed for day 7, and out of which 53 infants had intracranial bleeding detected on day 7, so amounting to 19.3%. So this is a violin plot. What we did was to kind of divide the outborn preterm infants that were transferred into 2 groups, those who had intracranial bleeding versus those who did not have intracranial bleeding. These plots will show yellow colored ones are the ones which had intracranial bleeding, and the blue ones are the ones who did not have any intracranial bleeding. As we can see that those who had intracranial bleeding had lower birth weight and also were more premature as compared to those who did not have intracranial bleeding. So we looked at a total of 46 factors across all the domains, as I mentioned in the beginning, from maternal, rhesus factors, infant factors, and transport factors. And the ones which were significantly different between the intracranial bleeding group and not intracranial bleeding group have been depicted here. And the one that we found in maternal factors, so antenatal steroids, was definitely different and was less common in the intracranial bleeding group as compared to those who did not have it. Again, with PPROM and chorioamnionitis was more common in the intracranial bleeding group in the maternal factors. In terms of resus, what we noted is that those particular infants who required intubation at the time of their resus was higher in the group of intracranial bleeding. So was also the use of adrenaline during resus, and that was also found to be more in the intracranial bleeding group. When we move on to the infant factors, as expected, what we found is that the cord pH and the first RPH was and the ABGA scores were lesser in those who had intracranial bleeding versus those who did not. In terms of transport, we looked at number of factors like the distance travel, location of birth, the mode of transfer. We also looked at scene time, the first look time, and the total retrieval time. But we did not find that there was any difference in those who had intracranial bleeding versus those who did not have it. What we found, though, also interestingly, was that those infants who were transferred, intubated, and ventilated were more in the intracranial bleeding group, and those who required inotropes during transfer also had higher rates of intracranial bleeding. With regression analysis, we tried to adjust for those factors, and we still found that this particular three were still different in between the two groups. So those the rates of PPROM and chorioamnionitis was still higher in the intracranial bleeding group versus those who did not have it. And the use of adrenaline in resus and the use of inotropes during transfer continued to remain significant with a very important p-value. So to say that neonatal transfer and retrieval factors are really complex in terms of untangling them, what we know for certain is that outborn infants who are small and who are more premature are likely to have more intracranial bleeding. And there was less intracranial bleeding in babies who had some sort of antenatal steroids, whether it was a partial course or a complete course. And in general, factors that made a baby sick at the time of birth was more predictive or was more associated with intracranial bleeding as compared to those who did not have intracranial bleeding. So probably there is need for intervention before transport, and these factors play a major role as compared to actual transport factors. So probably there is role for active obstetric management, especially centralized management in terms of transferring these ladies who are at risk of preterm delivery, especially those with risk factors like PPROM or chorioamnionitis, and try and bring them to central hospitals like King Edward's here in Perth, and trying to support the units for resus of these preterm infants when they are born outside. And perhaps this outborn preterm cohort actually behaves in a very different way as compared to the inborn cohort. So maybe there is some scope for a novel management. We would like to thank all our partners who support NETS WA, and thank you all of you for a patient listening.